not be altered at the time. Just kind of a disclaimer. This is a very wide range topic, very broad. So I'm going to try to kind of narrow it down. I've got two handouts up here. One of the kind of a mnemonic that I created to kind of help as you go through your differential. One that I thought kind of helped encompass some. I know there's several around, but got that for you. So again, kind of focus on differential initial workup. Hopefully tailored a little bit to our time in the fleet the next couple of years. And then certainly when you talk about the altered mental status, looking for acute versus chronic change, which in our setting we most likely see acute change over years. So when you talk about like decreased state of consciousness, decreased responsiveness, versus non-responsive, do they respond to painful stimuli? And also, talk about delirium, which is more like an altered perception. You see a lot of like waxing and waning with the delirium. And lethargy is more of just decreased activity, poor or loss of eye contact. And disturbance of consciousness could be, reduced focus, decreased sustained focus, with shifting attention, and then also changing cognition, more like you see an impairment more so with memory or maybe like perceptual disturbances. So just some quick statistics here. 56% of all hospitalized patients develop delirium, very much so increased with ICU patients. And really it's more of a marker for maybe more serious illness, increased mortality, prolonged hospitalization, increased discharges to nursing homes. So initial approaches, kind of how you approach anything in ED. You start with the ABCs. Glucose is low, administer the thiamine and dextrose. You want to avoid the worsening of possibly Wernicke's encephalopathy. And kind of for all patients, doing the ABCs, vitals, glucose first. Obviously, your history and physical is going to be important. It can oftentimes be difficult on an altered patient depending on the specific situation, and that'll be true as we kind of go through the talk. It will be very much dependent because, again, altered mental status can look like a lot and can vary quite a bit in presentation. But certainly having a good history, physical, knowing past medical history, medications are big, and then getting your basic studies, kind of work up of basics, CBC, CME, getting ready culture, chest X-ray, EKG, kind of the basic initial stuff. And then step 3 and 4 kind of guided by your initial exam, whether they need some further imaging, maybe an LP, and then more specific tests based more on the presentation. Some other factors to consider as you've got a patient who's altered. A lot of times having family at bedside to help, orient the patient. Having a clock in the room, they can get some time orientation as well. Minimizing invasive procedures, and to the extent that you can reduce the more invasive and in-depth exams. However, that you don't want to get that in the way of more diagnostics. Kind of vitamin H, as my psychiatrist in med school put it, to help sedate patients when needed. Should be a last resort, but certainly if there's any safety concerns, if you're concerned about your corpsmen or your nursing staff, want to make sure that you're in a safe environment as you're working up your patient. And then certainly getting kind of an overall picture, help direct your diagnostics, direct your workup. This picture just kind of made me laugh. Thought so I included that. Definitely knowing the baseline status if you can from either family, friends, people who are with the patient. You see this is an important aspect. Neuro exam is going to be big here, so cranial nerves, sensation coordination, gait, motor strength, all going to be important. Of course, pinpoint, pupils, you suspect opiates. If you suspect more of a midbrain lesion, we've got like a mid-position and fixed. Kind of keep that in mind. And the stuff that we don't do as often, it seems, or maybe I don't, oculocephalic, oculovestibular, just kind of refresh your memory. For the oculovestibular, the cow's mnemonic, cold water, same side, so the eyes should move toward the ear that you would watch with cold water. Certainly ICP can be diagnosed with papillodema, with pronator drift, and then when you see the bradycardia and hypertension, the Cushing's response with that as well. All things to kind of keep in mind. Neuroexam is really going to be key for anybody who's altered. So looking at your differential, different mnemonics that I'm sure you've heard, the AEIOU tips seems to be a popular one. B vitamin C, I watched that. But I kind of came up with this C shipmate, obviously with our relationship to the Navy, and I felt like it kind of included a little bit more. So we got those handouts up here. Hopefully you all got one as well. So start with the C. Think with cardiac, which should kind of be the go-to. Obviously, it's a little more serious if there's cardiac concerns. Could be more life and death. So. How are your intervals looking? If QT is a big one to look for. Good to get a baseline EKG, plus or minus a serial EKG. Certainly, if you have telemetry, that would be something to utilize if available. And basics, your pulse ox or ABG. Connective tissue is also another one, more of a vasculitis. Lupus can present with just about anything, so always keep that in the back of your mind. Certainly that would be less of an acute situation sometimes, but definitely something to keep in mind. Hopefully that you can elicit with a good history. So S, so stroke. The posterior cerebral artery strokes tend to present with more of like an agitated delirium. So if you got a patient who's agitated, delirious, they've got the risk factors, certainly keep that in mind for posterior PCA stroke. And a patient, that has a stroke more of the inferior division of the MCA, they could present with the Wernicke aphasia without any neurodeficits, and that can very much look like somebody who's just altered or delirious. So definitely something to keep in mind, kind of keep in your back pocket as a possibility. Certainly imaging would be utilized in that case. And so when you think of seizure, also think of like a post-ictal state would be big. Again, hopefully you've got the history on them, but if not, if they're in that state, that's something to keep in mind when you think as seizure, either post-ictal or maybe non-convulsive SE type picture. Shock would be another one for us as well. Again, hypotension, if you've got like a hypertensive encephalopathy, that can lead to altered state. Hypertensive emergency. Certainly hydrocephalus, like an NPH. I know I saw that here when I was on my ER rotation. Guy was just acting a little confused. Wife kind of endorsed, he's had some falls recently. He had chronic urinary incontinence, but he's got the wet, wacky, wobbly. Had the CT showed NPH, and so that was interesting. He actually had some good pathology down there. Hydration, certainly a concern, and also hepatic issues with like a hepatic encephalopathy, hepatic abscess. Consider getting an ammonia level if you think that's warranted as well. And GGT, getting that on them if you suspect kind of an alcoholic type issue in nature as well. And then hypoxemia is a big one, and it kind of included decompression sickness that we might see in flight dive, things to watch out for as well. So I for infection and intoxication. Certainly, that's going to be major in your workup for altered mental status. Check the basics: blood, urine, heart, lungs. Any source of infection, and not to forget like liver, colonic abscess, which kind of start with that basic workup: UA, chest X-ray, CBC, cultures. Intoxication, also a big one. Also keep in mind for intoxication, drug overdose, alcohol prescriptions. Start with your UDS, ethanol, Tylenol, aspirin levels, and kind of watch out for your shipmates. With what they're taking, and hopefully if your shipmates present with some issues like that, everybody's going to be of assistance for you. So P for poison, PE, porphyria, and psych. So poisons, you always want to think of like carbon monoxide. If people living in the same house are presenting with the same issues, that would certainly be a little bit higher on the differential. Other poisons, cyanide, pesticides, which again, hopefully you can kind of elicit by history. PE, you might be thinking check O2 sats, basic clinical presentation, kind of how they're doing, respiratory breathing, maybe get a dimer and PE protocol on it. For porphyria, getting a quant, PVG, porphyrins, creatinine. Usually that takes a little more time, so getting like an LA and total, the same sample might help. Certainly psych comes to mind when you're talking about altered mental status. Kind of want to rule out the organic causes, obviously, of what may be going on, but definitely if there's a psych history, schizophrenia, any psychotic type component to the presentation as well, with hallucinations and whatnot. So M for metabolic, first, hopefully CMP will be again kind of part of your initial workup. You could also be thinking about uremia. Methemoglobinemia is also another one. If you've got cyanosis, say we'll have normal arterial PO2 with symptoms of hypoxia. That would certainly be something to consider. You got your tests here. One aspect you can use. So your blood would be very abnormal in color, exposed to oxygen, unlike the deoxyhemoglobin. Malnutrition, certainly something to consider. Alcoholics as well. Be checking folate, B12 specifically as well. Medication's obviously big. If there's been any recent dose changes, whether dose changes or additions to any medication, certainly having a med list will help. One of the handouts is over the Beers criteria, or the Beers list, which is the potentially inappropriate medication to use for older adults or elderly population. I've included some major ones to look out for: the fluoroquinolones, anticholinergics, opiates, benzos, and steroids. You really want to watch out for. I did see that as a med student as well. This guy that just started some prednisone in the hospital. He was I walked in the room and he yelled. He was like, "Duck, duck, duck!" And he thought there was a war zone going on, like in the room, that he was seeing all these hallucinations. No psych history, had not had these issues before, but definitely stuck in my mind. Seeing this elderly gentleman kind of freaking out there. Definitely check levels. Anybody's on lithium, DIG, valproic acid, and certainly if you see like a CHF patient, not really sure med list, could be on DIG, worth keeping in your mind as well. So all things to consider. And metals, copper, you can maybe think about Wilson's disease, again, presentation, the other metals, lead, mercury. So here's, again, kind of the various list, different things to kind of watch out for. But hopefully that handout will
the busy slide.
Be a little resource. That is a busy slide, yeah. So A for acidosis, anemia, ammonia. Again, I know ammonia is kind of maybe something you think about with hepatic, but again, just kind of repeat it for completeness sake and hopefully not missing that. But symptoms of acidosis can certainly cause AMS. Hopefully your ABG will kind of guide you in that, which should be part of the initial workup. T for tumor trauma. This guy is likely to have some issues following his encounter. Definitely things to keep in mind. Either hematoma or hemorrhage. Certainly concussion, and thinking about like post-concussive states as well, which that can last weeks to months to even a year. So hopefully eliciting a good history with that of any head trauma, will be valuable too. E for endocrine, electrolytes, encephalopathy, and encephalitis. This guy's eyes were bulging so much it reminded me of a Graves type picture. But definitely endocrine is big, parathyroid, thyroid, glucose, insulin. Certainly adrenal insufficiency, is definitely something you don't want to miss, especially in the ED or, out at sea or wherever you are the next couple of years. Electrolytes also should be guided and able to be diagnosable based on your initial workup of BMP or CMP. Again, encephalopathy or anemic hepatic, and certainly encephalitis. Some references. Any questions?